You also want to look at glucose. Glucose that is normal doesn't indicate that there would be an infectious process. Usually what happens is the bacteria eats the glucose. So if there's a bacterial meningitis, what would happen is that the glucose will be low and the protein will be high. Okay. If you have a patient who has elevated WBCs, elevated protein, and low glucose, in that person, you're thinking that this is probably a meningitis, a bacterial meningitis. But you want to look also at lymphocytes and the neutrophils. If the patient has a viral meningitis, or it would be lymphocytosis. If they have a bacterial meningitis, it will be neutrophilia. So you'll have elevated neutrophils, elevated white count, elevated proteins, and low glucose for bacterial meningitis. Viral meningitis, the protein will be elevated, but not as elevated as bacterial. The white blood cells will be elevated, but you'll have lymphocytosis, not neutrophilia. And usually glucose can be down or just normal, okay? Depending. Now, in this case, you have a patient with elevated protein with normal WBCs in the CSF. That usually indicates that there's some kind of inflammatory process going on. Because if there's no white blood cell count, that means that there's no bacteria, there's no viral issue, there's no bacterial issue. Why is the protein elevated if there's no bacteria or viruses in the CSF? It usually means that there's an inflammatory process. So when you're looking at lumbar punctures, you have to look at all these things to try to deduce what's going on with the patient. Of course, you're going to put it with the patient's symptoms. And this patient was having weakness, bilateral. So we know probably there's an inflammatory issue going on. But you want to analyze the CSF completely to make sure that you can actually diagnose what's going on with the patient. Okay. Laura, is anything else?
Someone was asking if you could repeat the difference between bacterial and viral meningitis.
Bacterial, usually you have a neutrophilia, so you'll have elevated neutrophils. You will also have elevated white blood cells. You have elevated protein and low glucose. Okay. Viral, the WBCs will be elevated. You have lymphocytosis, so elevated lymphocytes. You have elevated protein, but it's not as elevated as bacterial. Glucose, there's no bacteria to eat the glucose, so glucose is usually normal. It could be a little bit low, but it's not as in bacterial meningitis. Any other questions, Laura?
Nope, that's it. Thank you.
I'm sorry, Laura. I appreciate you.
There's no big deal.
MRI of the brain in this patient. This is a normal MRI scan. You see the soul size of the brain. This dark is brain tissue. The white is CSF. This is probably a T2 image. And when you go into your clinical course and you start reading scans, we'll explain this a little bit more to you. I'm not going to belabor you with it here. But this is a normal MRI. This is a T2 image, and this is a sagittal cut. Sagittal, back and forth, right to left. Don't worry about it. Are there any diagnostic tests that you would perform prior to getting a lumbar puncture on a patient? If so, why? Let me see, Laura.
They're saying brain CT to rule out bleed.
The brain CT part is correct, but it's not to rule out bleed, but you're looking for edema. Okay? Because if someone has significant edema in the brain and you go stick a needle in their back, what you're doing is you're creating a negative pressure. So you're going to reduce CSF, you're going to create a negative pressure, and you can cause that patient to herniate. So you will do a CT of the brain. That CT of the brain is to rule out if there is any cerebral edema, okay? Someone with significant cerebral edema, you want to hesitate at doing that lumbar puncture because you can actually cause the brain, the structures of the brain to herniate. What's striking about the vital signs in lab? We talked about those. What pertinent information did you get from the history? The fact that he had the flu shortly before would be indicative. Anything else, Laura?
No questions here.
All right. Guys, do you have any other questions? Do you need any clarification on the CSF? That whole thing was just to introduce how to analyze the CSF. Remember, if you have a subarachnoid hemorrhage, someone comes in with the worst headache of their life, depending on how long ago that headache started, you may see a negative CT of the brain. If you see a negative CT of the brain and everything leads to subarachnoid hemorrhage, you don't say, okay, well, we're done. You have to do a lumbar puncture. And when you do that lumbar puncture, you're going to look for what we call xanthochromia. Xanthochromia is a byproduct of blood breakdown in the CSF. And that's very important for you to remember, right? All right, guys? All right. Case 13, 57-year-old African-American male presents to the ED with right-sided weakness. Dizziness started an hour ago. Temperature 0.7 as a heart rate. Respiratory rate is 16 and his BP is 225/110. These are all my ER nurses are going to jump at this one. We see these like every day. Okay. Hemoglobin 11, hematocrit 33, WBC 7.3, platelet count is 75. Sodium is 140, potassium is 3.7, BUN is 18, creatinine 1.35, glucose is 90. Past medical history is hypertension, normally controlled with 2 agents, obesity, hypercholesterolemia, and he's currently on a statin. What's striking about the vital signs and labs, guys? What are the 2 things you're picking out from the vital signs and labs?
The blood pressure and the platelets?
Blood pressure and platelets. Perfect. Yes. You have a low platelet and your blood pressure is significantly high. He's African American, hypertension, comes in with significant hypertension, low platelets. What are your first thing that you're thinking? This patient probably have a bleed. Okay. What type of test would you order? We said we need to get it fast. So definitely we're going to get CT of the brain. What's striking? We talked about the vital signs, the blood pressure and the platelets. What stands out in the labs? We talked about the platelets, I'm sorry. And what treatment plan for the patient depends on what's going on. He does have a bleed. He may need, blood pressure actually needs to be reduced before we do anything else. And then we probably have to consult the neurosurgical team to see what the treatment is. Yes, Cardine for sure.
Can I ask you a quick question? Someone was asking earlier the word that you are looking for, I think, in meningitis. I have to scroll up. The
Meningitis?
Yes.
No.
The meningitis, it starts with an X or a Z.
Oh, no, that's not meningitis. That's subarachnoid hemorrhage, and that's xanthochromia.
Oh, okay, sorry. I couldn't remember what they were talking about. Okay, thank you.
Xanthochromia. Okay. All right, guys. Dr. DK is a 59-year-old physician who visits his brother, also a physician, while vacationing one summer in San Diego. Says, my wife told me that the clinical manifestations are subtle at first, but are becoming more disturbing lately. The last time I had an episode, I would have fallen down a flight of stairs if she hadn't caught hold of me. She tells me that during one of these things, I do not respond to anything, but I don't lose consciousness either. She says that I just stare into space and fidget with my tie or button. I don't respond to my surroundings, and I don't seem to know what is going on at all. That I'm not in the present. It has been going on for about 3 weeks. In the last episode, last 3 or 4 minutes every time. At first, it was like 3 days. Now every other day. When I come out of it, I'm extremely confused, unable to speak clearly for some time. I try to talk, but apparently my words are incoherent. I remember very little about the attacks. I do not remember several things. However, the taste of what seems like soap in my mouth, and some mild stomach discomfort immediately before I black out. And when I become aware again, I feel a distinct sense of loss of time. And sometimes I feel so exhausted that I need a nap. I guess it's good because I've not had a grand mal yet, but it could be just around the corner. Now, we all know that this person's probably having a seizures. That thing that he says he plays with his buttons and he plays with his time. What are those called? Those are called automatisms. Okay? The smell that he gets and the taste of soap in his mouth, those are prodromes. Okay? And the feeling of tiredness and confusion after is a post-ictal episode. Okay? Now, his type of seizure is localized. Okay? We have different types of seizures. We have simple, partial, which means that they are awake, but let's say they have a lesion in the left posterior frontal lobe, and this is what they're doing. They can't stop themselves from doing that. They keep doing that, and they can't stop themselves. But they're awake, and they're looking at their hand, and they're going, why am I doing this? And they're totally awake. That's a simple partial seizure, okay? What this guy is having is a complex partial seizure because his eyes are open, but he's not aware of his surroundings, okay? They can walk during these episodes, they can perform different tasks, but they can't hear or interact with the environment. That's a complex partial seizure, okay? It's not an absent seizure. An absent seizure, usually what happens is they zone out and they zone back in. And a complex partial seizure is only part of the brain that's affected. An absent seizure, the entire hemisphere, the entire brain is shut down, okay? Just like a grand mal, what he said. A tonic-clonic is an entire brain that's involved. An absent seizure, the entire brain. A simple partial, meaning that they're having these episodes, but no loss of consciousness. And a complex partial, they're awake, but they're not aware of their surroundings. They have these automatisms. They have these prodrome symptoms where they can actually taste things or smell different things that's occurring at the time before the seizure occurs. So they can actually stop them and put themselves in a safe place because they know it's coming on. Okay. How are you going to assess this patient? You're going to do a full neurological exam, okay? And you want to look for different things. This patient has smelling and tasting issues. You want to make sure that you're going to scan the brain because you want to see if there's any brain lesion that's causing the seizure. Seizures are caused by metabolic reasons. They can be caused by brain irritation, by a lesion or a stroke or blood, okay? Because this has been progressive over a few weeks, you're thinking that there's probably a lesion, okay? What diagnostic test will you order for this patient? You can do a CT and an MRI. Remember, a CT is not going to show you much tissue. So in this case, this guy probably, it's been progressive and he's had it for a long time. So an MRI would be best to evaluate what's going on. Okay. You're going to definitely do blood work also, because metabolic causes and cause patients to have seizures. Although metabolic causes usually give you more tonic-clonic or whole brain involvement, you want to do an EEG. EEG would actually show you the electrical activity of the brain. So those are the diagnostic tests that you're basically ordering. Any questions? Dr. Abuha?
I don't see any.
No? Okay. Any comments? All right, guys. Take a deep breath and then go through. Now, can we have, I'm gonna open the, Dr. Abuha?
Yeah, what's up?
Okay, I just opened the chat. Can we have a 10-minute break? I have to empty my bladder. I saw messages popping up, but I can't read them, so that's why I was looking. That's what I was asking you. All right, guys. So yes, we can take a 10-minute break and I can drink something so that my voice can come back. And then we can move on to the lumbar exams.
Sounds good.
Sounds good? You're welcome, Marina.